بسم الله الرحمن الرحيم اللهم صل على سيدنا ومولانا محمد النبي الأمي وعلى آله وصحبه وبارك وسلم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. Now again, I'm Dr. Mudassir Shabazz, Associate Professor, Sahara Medical College, Naraval. In the previous lecture online, we have discussed about the anterior compartment of the leg, and during our discussion, we have seen the fascia, superficial deep fascia of the leg, compartments which are made by the intermuscular septa of the leg, and also superficial veins of the left, cutaneous nerve supply of the anterior compartment of the leg, and muscles of the anterior compartment of the leg. Now today we are going to discuss about the neurovascular component of the anterior compartment of the leg. And while we were studying, before starting, open up your book, and if you have atlas with you, if you open the popliteal fossa, there you will see that popliteal artery was dividing into two branches. It is starting from the adductor hiatus and it is running down deeper structure, and its terminal branches are the anterior and posterior, and one of the branches, the lateral peroneal artery, anterior tibial artery, posterior tibial artery, and the lateral artery. So two main branches, anterior tibial artery and posterior tibial artery. Because you are seeing the posterior compartment of the leg is the bigger one, so it needs a larger artery, while in the anterior compartment is a smaller as compared to the posterior compartment, so it needs a smaller vessel. And the artery, the anterior tibial artery, originating in the popliteal fossa, it has to move to the anterior compartment, and this will be accomplished when it will pass into the anterior compartment through a foramina in the interosseous membrane, in the upper part of the interosseous membrane. Here you can see the anterior tibial artery entering into the anterior compartment through the foramina in the sciatic nerve, a hole in the interosseous membrane, in the upper part of the interosseous membrane. So here is the origin and then the entry of the anterior tibial artery into the anterior compartment. The posterior tibial artery is running down here, and here is a branch of the posterior tibial artery, that is the fibular artery, on the lateral side. So anterior tibial artery. So what we have seen, that it's a smaller terminal branch of the popliteal artery, arises at the lower border of popliteal muscle. So popliteus muscle is a marker where starts the anterior tibial artery and posterior tibial artery. It passes forward into the anterior compartment through opening in the upper part of interosseous membrane that we have seen, and then it descends on the anterior surface of interosseous membrane accompanied by the deep peroneal nerve. So here is the point that this deep peroneal nerve has a very important relation with the anterior tibial artery, and as the anterior tibial artery is running down on the anterior surface of interosseous membrane, it means that it will be lying deep under the muscles of the anterior compartment of the leg. Now what we see, as I have mentioned in the previous slide, in this slide, that this artery is accompanied by the deep peroneal nerve, and it is lying anterior surface of the interosseous membrane, so its important relation with the deep peroneal nerve should be understood completely. And in this slide we see how this is here. This is present. So here we see that the posterior anterior tibial artery and then its relation with the peroneal nerve. So what we see that in the upper third, the anterior tibial nerve means that is the relation of the to the artery of the deep peroneal nerve is the other name in given in some books is the anterior tibial nerve. So it is the deep peroneal nerve which is having in its upper one third lateral to the artery. The nerve is lateral to the artery. Then in the middle third in front of the artery. And in the lower third it returns lateral to the artery. The deep peroneal nerve. If you have opened up the atlas and you see the compartment of the leg, anterior compartment of the leg, and open up the diagram which is about the anterior tibial artery, you will see that in the upper third the nerve is lateral to the artery, and in the middle third the nerve is anterior to the artery. In the lower third it returns back lateral to the artery, the deep peroneal nerve. At the lower part of the leg, the artery crosses in front of ankle and continues as a dorsalis pedis artery, and then the branches of the anterior tibial artery are given, which are on the which will be the tibial recurrent and also the muscular branches and malleolar branches. So what we see is that one of the two terminal branches of the popliteal artery is the anterior tibial artery. It will supply the structures in the anterior compartment of the leg and perforating branches of the lateral compartment, and the midpoint between the two malleoli, that is medial and lateral malleolus, it will enter into the dorsum of the foot, and it will be renamed as dorsalis pedis artery, and then at the end it will give medial and lateral malleolar branches. So branches of the anterior tibial artery we can appreciate here: posterior tibial recurrent, then is the anterior tibial recurrent, then will be the muscular branches, then will be the lower down will be the medial and lateral malleolar arteries. Very simple. So it means that what we understand actually is that these recurrent branches, anterior and posterior tibial recurrent branches, they will take part in the anastomosis around the knee joint with the genicular branches of the popliteal artery. Genicular branches of popliteal artery, they will form the anastomosis around the knee joint. It's very important anastomosis around the knee joint. And similarly, anterior malleolar, anterior medial malleolar, posterior medial malleolar branches, they will be taking part in the anastomosis around the ankle joint also. It is very important to understand. So here why I have chosen this diagram, because to show the relations of the artery. Here it is lying deep over the interosseous membrane, covered by the muscles of the anterior compartment. It's laterally is the muscle that is the, here is the tibialis anterior, then is the, here will be the extensor digitorum, and this will be the muscle that the extensor hallucis longus, and here is the neurovascular bundle lying. Posteriorly is the interosseous membrane. This is the tibia and this is fibula. So neurovascular, here is more well explained, that here you can see the artery, and lateral to the artery is the nerve, deep peroneal nerve. So this cross section should be either at the upper part, one third of the leg, or lower one third of the leg, because this nerve, hair nerve, is lying lateral to it. Anteriorly is the muscles anterior, tibialis anterior, and the extensor digitorum. These muscles will be anterior, and lateral to this is the other the veins of the legs, deep veins of the legs. So posteriorly is the interosseous membrane. So by drawing this diagram, we are able to understand the relations of the neurovascular bundle and its location in the compartment of the leg. Then is the common peroneal nerve. It's a branch of common peroneal nerve is branch of sciatic nerve, a sciatic nerve branch in the popliteal fossa, and from the popliteal it turns laterally, winds around the lateral aspect of neck of fibula. It's a dangerous position, because if you feel your leg laterally, you can feel the head of fibula. It's just like as in the upper limb, we have seen that the ulnar nerve was passing behind the medial malleolus, so that area becomes dangerous for the ulnar nerve. If medial condyle of the humerus is damaged, it will damage the ulnar nerve. Here, the nerve is very much closely related to the head of fibula, which you can feel laterally. And if there is a fracture of this upper part of the fibula, head of fibula, so how much chances are there that the common peroneal nerve would be damaged? And then it is divided immediately into the superficial peroneal nerve and the deep peroneal nerve. The superficial one is the musculocutaneous type, means it will supply the muscles and then it will become cutaneous. But the deep peroneal nerve is named as anterior tibial nerve or deep peroneal nerve. It will supply the muscles of the anterior compartment of the leg. So deep peroneal nerve is terminal branch of common peroneal nerve. It's arising from the substantia peroneus, longest muscle, which is a muscle of lateral compartment of the leg, and on the lateral side of the neck of the fibula. Enters the anterior compartment by piercing the anterior facial septum. So it will pierce the anterior facial septum and will enter into the anterior compartment of the leg. And it is enters the anterior compartment, piercing the anterior facial septum, descends deep to the extensor digitorum longus, first lying lateral, then anterior, and finally lateral to the anterior tibial artery. So same I have shown you in the previous diagram, relations of the deep peroneal nerve, especially with the anterior tibial artery, and passes deep to the extensor retinaculum. Then it will give muscular branches and articular branches to the ankle joint, obviously. So these important relations of the peroneal nerve, the question can be made by this, and these all are lying deep to the muscles of the anterior compartment of the leg. Whenever the common peroneal nerve is damaged around the neck of fibula, that will cause the damage to the muscles of the anterior compartment, and so the dorsiflexion of the foot is almost impossible. And then what will be the result? The result that the plantar flexors of the foot will become hyperactive and they will cause the foot to drop down. So the heel of is you are standing on your foot toes and not on the that is the heel. So it obviously then it will, while you are walking, we have noted that it's the first thing which you place over the ground is the heel of the foot while you are taking a step ahead, and for that purpose you have to dorsiflex the foot to let your heel strikes on the ground. But if the anterior compartment muscles they are damaged by damage of the deep peroneal nerve or common peroneal nerve, you will be unable to dorsiflex the foot while you are putting your foot ahead to take a step. So what will happen that then the walking will be interfered. You cannot walk. And the patient can flick the foot outwards while walking, known as eversion flick. Now, this is the foot drop which will be caused by the damage to the common peroneal nerve or deep peroneal nerve. Now we come to the dorsum of the foot. Is the dorsum of the foot. Skin, superficial fascia, deep fascia, and the modification of deep fascia is the retinaculum. The structures we will see in the dorsum of the foot are superior and inferior extensor retinacula, long flexor tendons of extensor digitorum, extensor digitorum brevis, extensor expansion, just like extensor expansion. Here is the extensor expansion, just like the extensor expansion in the hand. On the back of the hand, there is the extensor similar extensor expansion is here. Then is the dorsalis pedis artery will enter into the foot. Then there will be dorsal venous plexus, and we have seen before in the first lecture that on the medial side will be formed great saphenous vein. On the lateral side there will be formation of the small saphenous vein. The difference was that the great saphenous vein form anterior to the medial malleolus, while the small saphenous vein is formed posterior to the lateral malleolus. And all the tendons here we see they are covered by the synovial sheath, so to minimize the friction while they are entering under the retinaculum into the foot. So we'll see what we see. First is the dorsalis pedis artery, and here we can see that it is coming from above. Here the foot, the big toe has been dorsally flexed, and so the extensor hallucis longest tendon become prominent. And if we see that just lateral to the tendon is the dorsalis pedis artery, which we can feel, and it is extending forward on the dorsum of foot up to this area, which is the head of the metatarsals of the foot, just posterior to the head of the metatarsal of the foot, and it is accompanied by the deep peroneal nerve, which is on the lateral side of the artery. Now it is entering into the foot, supplying the two muscles, and here this area will be supplied, cutaneous supply of this area, first web, first toe, big toe, and the second toe. The web here is supplied by the deep peroneal nerve. So here we see the retinacula, that is the superior extensor retinacula, which is thickening of the deep fascia of the leg, and the inferior extensor retinaculum. I have discussed these attachments of these retinacula in the previous lecture because we have to understand the passage of the structure. And here you can see this is tibialis anterior, this is the tendon of extensor hallucis, and lateral to extensor hallucis is the dorsalis pedis artery, and lateral to this is the extensor digitorum longus. The peroneus tertius lies deep to it, and lateral to it, it will move towards the metatarsal of the fifth toe, peroneus tertius. But in this diagram we are seeing what this is extensor hallucis brevis, and we will see the tendons of extensor digitorum brevis, extensor digitorum brevis. So, extensor retinacula, superior and inferior extensor retinaculum that you have seen before. So, superior one, which is attaching to the lower end of the tibia and fibula, lower part of the anterior border of tibia and lower part of the anterior border of fibula, and function is to stabilize the tendons while they are functioning. Inferior extensor retinaculum is attached by the stem to the non-articular part of superior surface of calcaneum on the lateral side. Here you can see, and medially it is attached to the medial malleolus and to the plantar aponeurosis inferior band. So, dorsalis pedis artery, we have seen that it is a continuation of the anterior tibial artery while it is passing under the extensor retinaculum, and it begins in front of ankle joint at a point midway between the two malleoli, and it runs forward on the dorsum of foot accompanied by the two venae combatants of the dorsal venous arch, and it ends at the proximal end of the first interosseous space. The artery turns towards the sole between two heads of the first dorsal interosseous muscle to anastomose with the end of the plantar arch. So here it will move inside, passing between the first dorsal interossei into the plantar side of the foot to take part in the formation of plantar arch, dorsalis pedis artery. Here it is piercing inside and taking part in the formation of plantar arch. That we will see when we will look at the plantar side of the foot. So, branches, there will be medial lateral tarsal branches of the medial and lateral tarsal branches, and distal to the ankle joint of the tarsus, anastomosis around the ankle joint. There is an arcuate artery. Arcuate means arc-like. Arcuate artery. Arc-like. Here is arc-like. Opposite the base of the metatarsals. So here are the heads of the metatarsals. Here are the base of the metatarsals. Laterally in an arched course. That's why it's called as arcuate artery. Second, third, and fourth dorsal metatarsal arteries. Second, third, and fourth dorsal metatarsal arteries. The fourth dorsal metatarsal gives off a branch which supplies the lateral side of the little toe. The fourth one is which is supplying the lateral side of the fifth toe, little toe or fifth toe. So here is the main branch, that is the, here is the genicular branches, tarsal branches, which is supply the tarsal bones and the ankle joint. But here is the arcuate artery. So we have seen that dorsalis pedis artery is taking part in the anastomosis of the plantar side by its first branch, where it terminates, and before that it is giving an arcuate artery through which the second, third, and fourth dorsal metatarsal arteries they are originating, and they will divide into two branches. The first dorsal metatarsal artery arises from the termination dorsal. This one is the first dorsal metatarsal artery. Immediately before it pierces the first interosseous space, and it runs forward on the first dorsal interosseous muscle, divided into two branches, medial branch and lateral branch. So here it is dividing into medial and lateral branch, which will obviously supply the adjacent side of the toe, the phalanxes, the toes. First plantar metatarsal artery arises from the end of the branches plantar digital common. So common and plantar digital arteries will be formed, and they will be supplied. Then is the extensor digitorum brevis muscle. Extensor digitorum brevis muscle. Here is it lying, the extensor digitorum brevis muscle. Arises from the anterior part of the dorsal surface of the calcaneum, stem of the inferior extensor retinaculum. Four tendons The most medial is the extensor hallucis brevis. Then inserted in the base of proximal phalanx of the big toe. Remaining three tendons, they are second, third and fourth toe. Second, third and fourth toe. And they are all supplied by the deep peroneal nerve. So action will be extension of metatarsophalangeal joint of the medial four lobes, toes, extension of the interphalangeal joint of second, third and fourth. So this is the main action of the extensor digitorum muscle. Brevis, it's a brevis one. And here one thing to note is that the most medial side is called as extensor hallucis brevis. Some anatomies, in some books, the extensor hallucis brevis is considered as a separate muscle. But in some books, they say that extensor hallucis brevis is not a separate muscle. It is actually the most medial part of the extensor digitorum brevis muscle. So here we see extensor digitorum brevis, again the slide showing its origin, anterior part of the upper part of the calcaneum, and from the inferior extensor retinaculum, four tendons into proximal phalanxes of the big toe and longest tendon of the second, third and fourth. Not the fifth one. Second, third and fourth. Big, second, third and fourth. Extensor digitorum brevis. It extends the toes at the metacarpophalangeal joint. Extensor hallucis is considered to be the most medial part of the extensor digitorum brevis. So region will be the same, and the action will be extension of the metatarsophalangeal joint of the big toe, and the nerve supply is the deep peroneal nerve. So here are shown the extensor hallucis brevis separately, and these are the tendon of extensor digitorum brevis. Some says that this is one muscle, some says that this is a separate muscle. And here is shown the neurovascular bundle showing the branches of the neurovascular bundle. Here in this diagram have been shown the muscles of the dorsum of the foot. So we have seen the muscles and nerves of the dorsum of the foot, and now inshallah we will discuss the other compartments of the leg, and we have seen very important points that we have learned in this. In one of the lecture, inshallah, next time we will discuss as a whole the clinicals of the legs when we are completed, clinicals of the hip joint, clinicals of the knee joint, clinicals of the anterior compartment of the leg and others. One of the clinical we have discussed in this chapter, that is the foot drop we have discussed. In this, other clinicals related with the arteries and nerves we will discuss later on, and inshallah. And again, try to palpate your own dorsalis pedis artery on your foot, and then you will be able to understand. Try to feel the tendons, and then inshallah next time we will see the clinicals of all the compartments. Bundle of thanks. Allah Hafiz. Allah be with you all people. Allah Hafiz.